Hey everybody, our next session is going to be hosted by Eric Giza, who doesn't need an introduction, out from the Bay Area or California. And then he's got a great group of panelists who are going to talk about 3D printing for large defects. I do want to thank Alifair Biosciences for sponsoring this hour. Eric, it's all yours.
All right. Morning, everybody. Morning for us, evening for others. I want to thank Selene and everybody for having us here. And we're going to talk about some high-risk complex hindfoot deformities. I want to thank Dr. Parekh and his whole group for having us on. We have a great group. Thumbs up from Dr. Kreulen, Dr. Gross, and myself. So for some of these deformities, when you have a patient who comes in with something like this, obviously you start thinking of peripheral vascular disease, diabetes, neuropathy, and overall nutritional status. And the goals really are just to get the patient to have a plantar foot. Think of other things with these types of surgeries. A lot of people are malnourished, they're obese, they have all kinds of issues. So you want to look at their nutritional status beforehand. Certainly, we use regular imaging. I find CT scans very helpful for surgical planning. If you have a chance or the opportunity to utilize a weight-bearing CT scanner, here's Dr. Kreulen when we were visiting our colleagues in Chile in a weight-bearing CT scanner. It can give you that just a little bit more information about these types of patients. Again, the high-risk patients who trend towards non-union will be diabetic, smoking, psychiatric disorders. So take all those things into account, and then use your resources. Internal, external fixator, depending on where you are in the world, bone void filler, and then want to try and maintain the soft tissue envelope if you can. And today we're going to talk a little bit about biologic supplementation and 3D printed material. The other things to take into account, some of these patients, certainly with cerebral palsy, spinal cord injury, are good indications for using hindfoot nails or for some type of tibiotalar talocacondyl fusion. So the question often comes up, well, how well do these hindfoot fusions do when you decide to do one? And this study looked at just regular ankle fusion versus hindfoot fusion, and the traditional teaching was that ankle fusion the patients do better. But really, with this group, you just want to get a plantar foot, get them back to work, and the outcomes are pretty much the same for both. So the goals are proper alignment, minimizing height loss, making sure you're prepping the joint, and getting rigid compression. And then you just want to make sure you put the patient's foot in the right position, a little bit of valgus, a little bit of external rotation, and obviously neutral, and getting the talus under the tibia. Nails have advantages of length, alignment, stability, and you can address bone defects. A number of studies have been done to show successful outcomes in post-traumatic and rheumatoid patients. It does have some disadvantages. If it's infected, if it gets infected, it's difficult to manage. There's a little bit of a learning curve, and the older static nails can have loss of compression over time with bone resorption. So here's an example: diabetic Charcot fused him with an IM nail. It didn't work, but he is painless. He was insensate, so I said, okay, we'll just let you roll. And then of course he came back with a fractured nail. So what do you do now? This I put in an antibiotic spacer and then went back, and you can use the external fixator, and there's a decent amount of healing with this. One option, depending on which country you're in, we can use an allograft. So that's a acetabular reamer, and we then shape an allograft, put it in, and this did fuse, so great. but then he fractured through the allografts at a year and ended up with a below-knee amputation. So the challenge we have, and kind of the lead up to our discussion for the next few minutes, is better nail and a better, do we have a better bone void filler? So, as we know with fusion, mechanical factors, you need compression at the fusion site. And some of the older static nails will lose that, particularly in these diabetics, because they have resorption around the fusion site, which is a lot slower than a normal patient. So IM nails decrease when they have a millimeter of resorption. And external fixators, obviously, when you let people put some weight bearing through them, have better compressive forces. So there was a commercial company that started using nitinol, or a memory metal, to give sustained compression through the fusion site, and they compared this to an external fixator and then the traditional nails, and you find actually that the nails with nitinol actually have a better compression. So there's been a number of publications for this, Kent Ellington and some others, Dan Latt, Parekh, even Dr. Parekh himself kind of showed. And then looking at our data from UC Davis with my partner, Dr. Chris Kreulen, we showed that we had a better union rate with a compression nail. So here's somebody with some bone loss. This was a case from years ago. We get sent these cases. Thank you very much. It's infected. I did not do this initial fixation. As a disclaimer, put in the antibiotic beads. And now what do? Well, I was left with this big gap. These memory metal nails had just hit the market. This is about 2010 to maybe 2012. So we did RIA, some bone grafting. And at the time, there wasn't any 3D printed metal available. So I used a knee augment, a total knee augment, bone loss augment, and put that in there. And it fused at a year, and even sooner than that. So this kind of gets onto the next generation of 3D printed cages, which we're going to talk about today. A lot of different uses. You can customize your fusion site. There's been a number of studies showing this is a kind of the next generation for large segmental bone defects. So this is what it looks like. That's myself and my partner, Dr. Kreulen, visiting one of the sites, and that's what a 3D printer looks like. It lays down a little bit of metal, like a millimeter. The laser burns or does whatever it does, and then you get what you see Dr. Kreulen holding, these 3D printed parts. So here's an example. 57-year-old diabetic Charcot ankle comes in, like, where's the talus? So we did this 3D cage. You can coat it with your biologics, little potpourri there, and you can get it set. They'll print it ahead of time, so you can actually figure out where you want extra screw holes for this to help with a TN fusion for it. And then you get compression applied across this site. And this was the patient at 4 months, came in, was healed. Another one, a patient was sent to me with literally, there was cement, just regular, bone cement sticking out of the side, big skin loss. So we took him, got the skin to heal, put in a antibiotic spacer and a frame, and then you get your 3D planning guide for the next phase. And this is what it'll look like. You have on the back table, and then intraoperative, you measure everything out, and then put your nail through it. And this was the patient at 12 weeks. And then this was a patient at 1 year. This case is a patient I've been taking care of many years. He's a 18-year-old, spina bifida, born this way, lived in these HKAFOs and wanted some freedom from his AFOs. He did have quad and hamstring function, kind of would, just kind of clop around. So we put a frame on to stretch his skin because he had 50 degrees of valgus. And he only had an 8mm tibial canal. So I used a humeral nail and some compression staples. And he fused at 3 months. So I thought, great, we'll just do the same thing on the other side. Of course, the other side gets infected and has a non-union. So we cleared the infection with a spacer. And then we went for lateral plating because, again, there was no nail available that'll fit in this kid's tibia, non-union number 2, which is a pretty big bummer. And so 3D printing to the rescue. So we're able to use this cage, kind of planned everything out. How would we get, anything to fuse with what's left of this kid's ankle? And he healed at 6 months. So this is him now, and he's doing well. So for high risk fusion, it's a difficult patient population. Techniques have definitely evolved. Biologic augments I use often, and then consider, if available, wherever you are in the world, the 3D printed material, retrograde nail or plating is a reasonable surgical option. So thanks for your attention. I'm going to turn this over to my esteemed colleagues here.
All right, my name is Chris Kreulen. I'm colleagues with Eric Giza at UC Davis. I'm going to talk a little bit about 3D printed wedges. I apologize for my cold. And the wedges are more of where 3D printing is going into a manufacturing type of production. And then also show a few or a couple mid-foot and forefoot, or basically mid-foot cases to show you what you can do with 3D printing. So first, now 3D printing makes wedges off the shelf. So when you're doing flat foot reconstructions or triple arthrodeses, you have an ability to use a cotton wedge that has been 3D printed and designed by a couple surgeons around the United States. There's also an Evans wedge that you can use. So instead of using allograft or a plate to hold the space that you created, you can use this wedge to fit into that area. Again, also designed by some surgeons around the United States. Here's a couple more views of it. Obviously, a couple examples. So some people like the use of these. They're available in a tray, in a peel pack. And they don't like the resorption seen with allograft, so they prefer to use a metal wedge. Then here's some examples. So here's a simple flat foot correction where a cotton and a calc slide and a tendon transfer was performed. And you can see that metal wedge in the medial cuneiform. And it has kind of an anatomic design to fit that cuneiform so you're not impinging over on the lateral side. Here is a double fusion, and then the surgeon used a cotton wedge again to correct any residual forefoot varus. And then finally, here's a bit more of a complex flat foot that had a lot more deformity, and so an Evans was determined to be used as well, along with the cotton and the medial calcaneal slide. Next, I want to talk a little bit about arthritis and subtalar collapse. And as we know, we'll see these walk into our clinic, the missed calcaneus fracture or the collapsed calcaneus fracture after having an open reduction internal fixation, or sometimes open internal fixation if it hasn't been really reduced. But a patient obviously has lots of problems. One of their big complaints is subfibular impingement and also anterior impingement at the tibiotalar joint. And it's our job to fix that. And so, it's difficult with what we had as resources to either we don't distract and we just try to fuse them. And we have these issues that allograft can fail. And here's a perfect example of one of my cases where a year out, this gentleman jumped off of a pickup truck because he was a construction worker and he felt a pop. And the allograft that he had, which had fused on CT, subsequently compressed and he broke his screw. So we had to revise that. Here's another gentleman who fell off of a 30-foot roof and managed to live, but had this calcaneus and was having difficulty and with motion in his ankle. So the goal was to try to approve that or improve that. And so this is where 3D printing has really come in, because you can decide, well, do I want to use something that's off the shelf, a wedge similar to the Evans or the cotton wedge, or do I need something custom? And like Dr. Giza showed, there was the use of those knee spacers or the augments, those trabecular metal augments in the past. And in the past, we would try to use those, but now we can be even more precise by using 3D printing. So here's an example of that patient getting a custom. Show the video. So it's a 2-incision approach, leaving that skin underneath the fibula intact, and then putting in this large, I think it was about 2 centimeters wide, and restoring that tibio-talar joint so you can see, and then compressing through it. And there's some restoration of the tibio-talar joint to improve his ankle motion when he walks. So then what about off the shelf? So a lot of times we'll have patients like this that you see where the subtalar joint is collapsed, and therefore they have some anterior impingement at the ankle joint. And you don't really want to use the allograft because what I discussed earlier, you have the collapse, you have the risk of no integration. And so these metal wedges are available, and they have excellent bony integration, and you can dial in your varus valgus and also your elevation. And so here's a patient after that. So no pain, improvement in ankle range of motion. And this patient actually just stopped following up. So I always take that as a good sign, because they're doing so well, they don't want to drive down a few hours to see the doctor. So the idea behind the wedges is that you don't want to leave a gap. And in the past, we didn't have something that was available besides an allograft. So you prep a joint after a calcaneus fracture, there's collapse. And once you get in there and take out some of the hardware, you're left with this gap. Well, how do you fill that gap? Well, that's where these metal wedges are available to do so. And this is all made through 3D printing. And it helps restore that weight distribution throughout the entire foot, instead of a posterior collapse and having a lot of pain and the weight distribution just staying in the posterior hindfoot. And then here's kind of my little GIF showing the trial in there and that dramatic improvement in the tibio-talar joint with that distraction. And then also, we're all going to get revisions, whether they're ours or from someone else. And you can see once those screws are removed, there's going to be some fibrous bone, fibrous tissue, and a lack of bone. And once you prep those joint surfaces, you're going to be left with impingement anteriorly in the ankle. And here's a larger wedge that's able to fill that gap so that you can restore your ankle motion. Now, when it comes to an incision, I've done them all. And I like to go more lateral. I don't like to always have my patient prone for these, but you can do that kind of posterolateral. But I've always found success now with these 2-incision approach, and then being sure to leave the tissue from the line that is parallel with the anterior fibula and going plantar, and leaving that area alone, because that's the area where you're going to get most of your tension. And so if that's the difficulty with these distractions is skin closure, that by leaving that area of skin native and not cutting on it, it will allow a better chance of healing. And so I've had a lot of success using this 2-incision approach. You can take care of that anterior subtalar region through the sinus tarsi approach, and then you have your posterolateral approach, and that usually allows you to insert the implant while distracting the joint through the sinus tarsi. So I found this to be most successful. So here's some example, or I've already shown examples. So then this is from my friend Sam Adams. And the idea, we're getting to this point of, well, what can we do? What can't we do? We'll show some examples about total taluses. But here's a guy who was a police officer, and his navicular bone graft failed. And so he's having avascular necrosis of his navicular. Well, trying to preserve a joint, you can create a 3D printed piece of metal that does mimics the bone, and you can create one side to have a fusion. So you have the navicular cuneiform side, and you create a little plate, and then you keep it smooth on the talonavicular side. And we're able to pass the PTT tendon as well. And you can see, and so here's that gentleman, there's his x-rays. And then, yeah, and the next we are, here he is moving, walking. So pretty impressive. You probably wouldn't even know that he has that in there. And he was able to return to work. And that's pretty amazing. So we're still kind of in this modality where the sky's the limit with what we can do with 3D printing. And I think Dr. Adams' job of seeing where it can take us. Then here's my final case for my portion is a midfoot salvage. So this gentleman who's neuropathic but non-diabetic showed up with this non-union. And so the plan was, okay, we'll take this out and do a revision fusion. There was no risk, no signs of infection. So did a revision and also a first MTP fusion, and everything was aligned up pretty good. And we thought that he was going to do well. So weight bearing began at 8 weeks, and then he presented with a screw sticking out of his foot, and everything had broken. So there was basically we assumed this was infected at that point. So went back and took everything out and did a staged approach. So put in this antibiotic spacer that you can see, took out all the hardware because his first MTP joint had fused, got all the screws out. And then after he did the PICC line with 6 weeks of IV antibiotics and took him back. And here's some pictures of popping the cement out. And then there's this large bone gap. Well, before 3D printing, this probably would lead to either a high transmetatarsal amputation through the cuneiforms, or some kind of frame and trying to get allograft to bridge that area. But he'd already failed some allograft that had been placed in there and got infected. So we need something better, and that's where 3D printing comes in. So this gentleman had a custom 3D printed medial cuneiform that you can see here. And when you plan it out with the engineers, you plan your cuts and everything. And one of the reasons I think it failed in the first place was I probably didn't have enough biomechanical stability. So I used thicker plates. I designed this to have a screw go through the plate and then through the implant, as you can see there, and then also placing a plantar plate to support the tension side. And then we watched this gentleman. I think this time I kept him non-weight bearing for 12 weeks. But here I just saw him this week at 7 months. He has decreased swelling and got a CT scan. And here's pictures to show the integration of the bone into this 3D printed design. And then my final pictures, some of the questions are, will this integrate? And I've been doing 3D printed implants for 5 years now, 6 years basically. And these are some images. So there's a subtalar in the middle, and then on the sides are some critical bone gaps for the ankle joint. And it's just showing you on CT, there's bone going through the main hole, bone integrating into the tidal design in these implants. And I just would say that the bone grows into this metal, and I think it's a lot more reliable than allograft, and we can do a lot more, and we can save more limbs. So limbs that I used to amputate, I can now save with the use of this 3D printed implants. All right, thank you.
Thanks, Chris. I mean, that's great. That's definitely been a kind of a bit of an evolution of what we do, because I agree, as I showed, that the allografts will only get 1 or 2 millimeters of ingrowth, and we're about to start a study with our vet school on the ingrowth into sheep. Are you using Kreulen? Are you using RIA? Are you using biologics? What do you put? Do you coat that 3D print?
So in the beginning, I was using a lot of RIA. I luckily have fellows who still know how to ream a femur, and so I would just use them. And but it started to be too much bone graft, and I I think, the original spacers that you and I would use, the trabecular metal, there was a little more room to place the bone graft so we could use it. And we've even published on that. But as we get the 3D printed where you have the metal, and they've done a lot more research to fill the bone gap with these porous structures that are a little more biomechanically strong, I don't need as much bone graft. And so now I've gone to either proximal tibial or calcaneal bone graft and just leave it at that. And it's not as invasive on the patient's knee. And I think that's a lot easier, and it's quicker. So I'm out of the OR quicker and less anesthesia for the patient. I think these modern 3D printed designs that these companies have, really bone just grows into them, and we probably don't even need much of anything in there. You can just fill it with the 3D printed, and then it's more about the compression and stabilizing that metal than it is getting more biologic around there.
As a precursor to your talk, Dr. Gross, are you using biologics as well? Or?
Yeah, so I'm not using too much of autograft. Sometimes I mean, earlier on I did use urea, but like as Dr. Kreulen was saying, it's just way too much. So my philosophy is I really want to cover, two areas, at the implant interface and then at the ankle joint, specifically posteriorly along the posterior capsule. I'll kind of go over that in my talk, but lots of biologics just at those interfaces, simply because the whole point of the 3D printed, bone, if you will, it is now architectured so well that it's just supposed to mimic, what osteoblasts love to grow into. So I just kind of leave it as is.
Give the bone a home, right?
Yeah.
All right, take it away.
Thank you. All right. I'd like to thank Dr. Parekh and the Parekh Family Foundation for the opportunity to discuss all these important technological advances in saving people's limbs. I'm going to have a little Charcot bent on this just because that's where I find a lot of my patients to be coming from in my neck of the world in Charleston, South Carolina. So, there is a greater risk in type 1 diabetics for Charcot arthropathy, but, we are diagnosing more Charcot arthropathy. The prevalence is increasing as diabetics are living longer, as diabetics are becoming more diabetic. So we know that with a foot ulcer, there's a 12 times more likely chance to have a major amputation than those without ulcers. When they start developing ulcers, sometimes they start developing bone loss and things like that. Okay, so historically speaking, we would just toss people in crow boots and say, good luck, but it really doesn't improve anyone's quality of life. They're difficult to brace. They don't like walking in the brace. They end up just walking without it. Their ankle starts to collapse and their ankle starts to melt away. So these patients that you're putting in crow boots are at a significant high risk of amputation. So, if you're just doing it simply because there's just some critical bone loss in the ankle itself and you really don't want to operate, that's not really a good excuse anymore, simply because we have such great technology in order to improve these patients' lives. So always the goals of surgery for these patients is limb salvage. So you want to resolve the infection if there's an infection and restore a plantar foot. You just want to get them into a shoe. And for me, it's someone with a fixed varus or valgus deformity, those with rocker bottom deformities. I call this the sidecar joint, so a dislocated ankle and subtalar joint, and those that cannot heal their ulcers. So we know that these patients have a higher complication rate than midfoot when we're working on the hindfoot, but you really need to correct all the deformities through your osteotomies, and then I find it really necessary to restore their length. And we'll talk about something similar to Dr. Giza did in terms of stabilization, what are kind of our considerations with that. So, patients walk with a better gait. We keep the soft tissue at the appropriate tension. We know that we're going to remove structurally horrible bone when we're operating on these patients, so you have to have this planned out, and we want to replace their biology. So when we're working on the ankle joint with these patients, you can't not just perform a normal fusion. You need an IM nail, and you need to get rid of the bone that is not going to be very bone-like. So, these bones will melt away and these bones will disintegrate when you start touching them. So you want to consider what to do. So early on, we started doing bulk allografts. So they're, usually we're using a femoral head. We want to do this in order to improve alignment and restore height. The issue is that there's still a risk for bone collapse. Typically, when we're planning these out, we want to aim, you're going to want to get your acetabular reamers that match the femoral head, and typically it's about 41 to 46 millimeters. And again, even though you're proud of yourself that you place this in, it looks perfect, as you can see on the bottom right, it can still collapse. So let's make a case for 3D printing. So with 3D printing, it creates a highly conforming implant of any shape that you want. And yes, it's a little bit of expensive, but the cost is going down quite considerably. So simply, when we're working on the ankle, you can create simple shapes. Here we have our spherical femoral head. Well, it was not that terrible of a leap of logic to get your spherical 3D implant. So why spheres? Not only is it just simply a beautiful geometric shape, but what it does allow is you can dial in the amount of varus or valgus that you want, and depending on how you look at your, especially if you design these holes very well, you can get a varus valgus deformity. You can kind of dial in your dorsiflexion and plantar flexion where you want that foot to sit. So you can rotate the sphere in situ to allow the passage of the nail. Again, if I'm doing these types of spherical implants, I'm typically making oblong holes right here. So there's a little bit of wiggle room, so I can, if I'm not exactly perfect where I have reamed, I can certainly, there's a little bit of a fudge factor. And another thing is I'll always design, a little screw hole so I can kind of insert an instrument just to kind of wiggle it around and also help with the reduction and putting things through it. With spheres, you can create patient-specific custom sizes. So typically what you do is you're building the implant on the contralateral CT scan of the ankle to try to get a better idea of height and bulk of the talus that you're replacing. These do not collapse. It's impossible for these metal spheres to collapse. So that's the one nice thing. And it obviously has stronger mechanical properties. And they can be coated with different things to help prevent infection. And just the nature of certain metals like titanium and titanium dioxide, which is formed when the titanium layer oxidizes, is antimicrobial properties. So Dr. Adams reported on the comparison of a femoral head allograft to a 3D printed spherical implant. And there's some notable things here. So number one, the total fused articulations was significantly higher in the 3D printed one than the femoral head. And as we demonstrated, or as we stated before, and now we're demonstrating here, is that the graft collapse for femoral head was 57% in this group, and obviously 0% in the spherical group, 3D spherical group. And there's no different in complications. So that seems like a win all around. Now, one of the things that you also have to consider with a study like this is kind of the bias of whether or not you believe that this limb is salvageable or not. I don't know if a lot of us are going to be placing a $15,000, $10,000 custom cage in someone who the likelihood of saving the limb is small. So that's another consideration. Now, I don't like spheres too much. I have tinkered around with many different types of designs. And why not sphere? So I like to keep the foot out to length, and I'm not sure when we put the sphere in, what's really happening between the articulation of the hind to the midfoot to the forefoot. So I feel like it's more structurally sound. Obviously, there's a better articulation at the TN joint. There is a nice smooth surface for some plantar flexion and dorsiflexion. Not a lot, but it beats nothing. Doesn't rely on your lateral column to retain length. And I think it helps align our forefoot and just link it better to the hind foot. And maybe it's just me, and when I started designing these, maybe I just had a thing for Mario Brothers 3, because that was my inspiration for it. So what are my 3D printed options? What can I print and put in the human body that will be structurally sound enough to withstand the forces of someone with Charcot or someone with critical bone defect? So the first thing that comes to mind is obviously titanium. It's highly resistant to corrosion. So obviously in the body, you do not want anything to corrode, or that's bad news bears. The modulus of elasticity is close to bone. So it's reducing the amount of stress shielding that the surrounding bones that are around the implant are going to see. For how little it weighs, it's extremely strong, and that's very important. You want something that has a decent strength to weight ratio. And then I briefly mentioned titanium oxide and dioxide, and this layer forms with basically minimizes metal ion release and also allows for osseointegration, which is, again, the whole point of why we're doing what we're doing, unless we're talking about total taluses. They have 3D printed tantalum. There's a case report of that. And, we have a lot of experience when we were doing our joints rotations with tantalum. It is very osseointegrative, more so than titanium ever could be, but it's expensive. The metal itself has a very high melting point, so it makes it not ideal for 3D printing the metal itself. They do have a powder now that is made that you can 3D print with, but again, very expensive. For load-bearing implants, I like using a cobalt chromium alloy, and that's when I'm doing like a total ankle with a total talus, and I'm using the total talus itself will be made with cobalt chromium. When it's just a total talus by itself, I'll use titanium. They are, engineers are getting more into biodegradable metals, and I'm extremely excited about the magnesium kind. So if we can 3D print, a magnesium titanium alloy, and this is going to be disappearing in the body in 2 to 3 years, and of course they can dial that in. I'd much prefer something like that where the body can just take it over. So that will be fun. And a new kid on the block is PEC, and I'll briefly talk about that. So it's not PEEK, it's a cousin to PEEK. It's a polyether ketone. For those that don't remember biochemistry, don't worry about that. It's very biomechanical, and in many studies has antimicrobial properties. It does have a really interesting osseointegration pathway. So it has really good topographical roughness, which acts as a scaffold for these mesenchymal stem cells to, again, attract osteoblasts, become osteoblasts. Whereas something like PEEK, it's really an inert material, but also not only inert, but over time the body can mount an inflammatory response to it. The elasticity of, the elastic modulus is more favorable than titanium. And in a study that will be coming out shortly, the wear debris of titanium articulating with polyethylene versus PEC is that it's decreased wear debris. And these things can be stupidly easy to print, and they can print in 2 to 3 days. All right, so let's say you want to build a cage. What you really need to do is keep the cage in its place and generate compression across the forces like Dr. Kreulen was talking about. So why are we using a TCC nail here? It provides better stability. It gives you, allows for a load sharing device to allow early return to weight bearing, though if I'm doing these allografts, honestly, I'm keeping them non-weight bearing for 12 weeks. And sometimes asking my partner, Dr. Scott, to come in and toss a frame in at the end. We want some axial compression, and depending on the type of implant that you use, dynamic versus static, you can achieve different varies of compression. It's rigid. It is a very strong fixation construct, and it's stronger than a bunch of screws. So what do I fill my 3D cage with, as Dr. Giza and Dr. Kreulen were talking about earlier? I really throw the kitchen sink at it. I'm using stem cells in patients with bad protoplasm. I'm using crushed cancellous. I used to use rhea, but I'm also using these types of bone fibers that have been processed in such a way that it retains their growth factors as well. So really, I'm throwing everything at it. Where do I pack it, though? It's really at the bone implant interface. And something that I learned from Mark Meyerson is really you want to pack and respect the posterior capsule. And you'll find that when you're looking at your spheres and your boots and your cages, the place where you can find where the bone is growing and you know you have a successful fusion is in the posterior capsule. So pack the heck out of it, pack. Use that crushed cancellous, some bio, and pack it up. So nail considerations. Every nail has its own advantages and disadvantages, but you must keep the Charcot properties in mind. So if I'm using cages, I'm typically using dynamic compression. So the challenge is with the poor quality of the native bone, we need to keep compression going. Dr. Giza mentioned the 90% reduction in load with just 1 millimeter of bone resorption. So we need to sustain compression over time. So we know that if we use sustained dynamic compression, it allows for immediate dynamization. So we don't have to take out a screw. We don't have to take the patient back to the operating room. As the bone resorbs, which is completely natural, you are going to see it compressed with it. So it also has less stress shielding. So 86 patients in a cohort of sustained dynamic versus non-dynamized nail. Similar fusion rate, no complication difference. However, the dynamic compression nails had a significantly faster time to union, which is extremely important when it's oftentimes a race against the clock. I sometimes do super constructs with a static nail. I have not yet done a dynamic nail plus a frame, simply because the dynamic nail is too long for the ring fixator. So that usually the dynamic nails, the shortest is 220, the one that I use, and that's kind of where you're going to be putting your proximal ring. So obviously there are complications with these TTC nails, non-union, bone failure, stress fractures of the tibia. And what really helps predict our outcomes in metalwork failure with these Charcot reconstructions. So improved union rate, 3 things to take away from this. Use of a supplementary compression screw. So now I'm putting a screw like this across the fusion site. I try to preserve the medial malleolus as much as I can. And then one thing that improved their union rate is having the thickest nail possible. And that's important when you're designing your implants as well. So this is another opportunity for 3D printing. Again, it's called a sidecar. It's like a subtalar dislocation, and it is just a beast to deal with. So, you have to release all of your soft tissues, deltoid, spring ligament. Please open that up immediately. But you have a couple of options. You can remove the talus, reduce the calcaneus, and put the nail in. But now these patients are 2 inches shorter, so I really don't like that. So what I'll do typically is fibular osteotomy, aggressively cut the tibiotalar joint, and be as aggressive as humanly possible. Sometimes I will 3D print an implant, just almost like a half sphere, in order to kind of make up for the loss of talus. But oftentimes I just perform a talectomy and use the talus as its own allograft. So I'm just going to show one case right here. So this is a diabetic smoker. He's a chef, so he's on his feet all day. He loves to drink. His A1C is 12.5. He cannot feel anything. So I was trying to, once I saw these X-rays, and he came in like, 3 weeks after his injury, because he really didn't feel it. This is what we were left with. And again, in a normal person, this is a very, simple thing to fix. Well, not simple, but it's fixable. And you'd expect them to develop post-traumatic arthritis much, much later. But, given that he was a neuropath and a diabetic, I thought it'd be best to, put him in an ankle fusion. I maybe should have considered a TTC, but this seemed like the best idea at the time. So I was really proud of myself, patting myself on the back. Saw him at 2 weeks. His incision's healed. He's doing great. He's not having any pain. I put him into a cast. So I see him 4 weeks later, and he has a hole in his cast, on the bottom of the cast, and he is excited to go back to work. He's now 6 weeks out, no pain, feels great. And then I get these x-rays, and it makes me very, very sad. So sad that, we have to take him to the operating room pretty quickly, take all this out. I'm afraid of infection. I'm afraid of all the things that we'll have to do. But essentially what we had to do is we removed the plate. We removed the distal aspect of the tibia because it was just shattered. We sent this all for biopsy and culture. And then we had to put him in a circular frame. And basically, I just filled the space in with antibiotic cement. And of course, these aren't great x-rays, but we're doing our best with the circular frame. So I just wanted to keep him out to length, decently aligned, and live to fight another day. So here's a CT scan of it. And I needed to work quickly because I knew once we get his blood sugars under control, he's going to start drinking again. He's going to start being a bad diabetic again. But he got his sugars under control, and given the limited amount of time in the large defect, I decided to go with PEC this time. And here you see the intraoperative photos of top left is just the, and it's hard to see, but that's on purpose because it is a bioplastic. So anyways, this is, you just made flat cuts along the talus, flat cut at the tibia. You want to make sure you have at least one fixation above where you were compressing through. This is where he is 4 weeks. So you can see that the implant and the bone are looking fine, and the compression nail has done its job. And here we are 3 months post-operatively, and I was getting really excited. He's not having any pain. He's walking on it without difficulty. And you can see osseointegration, and here he is 4 months out as well. So he's healed everything 4 months with an uncontrolled diabetic. But what's interesting is you can see the bony shell that forms around the implant, and it really formed along the entire thing. So here's a CT scan that we got of this. And you can see the bone that grew around it. It's incredible. There we go. All right. I have a lot more cases, but I want to defer to Dr. Giza about more questions and conversation.
That's amazing. The amount of integration is really impressive, particularly in someone who you pretty much had everything that you could have that we don't want. Just a diabetic, or just a smoker, or just an alcoholic. He's got it all.
Oh, yeah.
Those are some great cases, and same with Dr. Kreulen. I think it's difficult when you're in the situation where you're taking on these really difficult patients, and I think in the past, Dr. Kreulen and I would do a lot more baloney amputations. I think before all this technology, I would have thrown in the towel, probably maybe even after the first case on this guy. So those are great outcomes. I'm not seeing any questions in the chat. So I thought maybe I'd just, in the last remaining minutes, just put a case up for us. Let's see if I share again.
Hey, Dr. Giza, I had a question about, you showed this that awesome case pretty early on in your presentation about you fusing a guy with a frame for 6 months with a bulk femoral head allograft, and then you fractured through it. So 2 questions. Number one, do you feel like if you had the technology, then you, say you put in a sphere and got him to heal across it, that outcome would have happened? And B, do you feel like if it integrates, it's worth our while to put something metal across it, knowing how poor quality, the guy's, taking over the bone, resorbs the bone, and the bone becomes his. Do you think it's a reasonable consideration to put a nail up after you demonstrate fusion?
Yeah, no, obviously that case was from like 12 years ago. So,
right, yeah.
But that's a great question. Certainly now I would, but he'd already failed a nail, and we didn't have the dynamic compression nails at the time. And the interesting thing is, when I went back to do his amputation, I kind of then cut open the allograft and basically he fractured right through the center of the allograft, the femoral head. So he had integration on either side, and he broke through the center of it. So certainly, it's a good point that utilizing the metal technology is going to give that strength and stability.
There's a question in the group chat.
Oh, there it goes. Okay, good.
So the question is, have you guys seen the subsidence in the adjacent bone with titanium 3D implants? And that's the first question. And the second part of that is, do you feel that risk is lower with PEC?
So I do see subsidence in the adjacent bone, and I'm just starting my work with using this different type of material. So the jury is definitely still out. I do feel like the risk is going to be lower, hence why I'm looking at this a little bit more closely. So yeah, I mean, that's one of the reasons why I'm doing it, and I feel that if we can get that technology a little bit cheaper, then I may be a lot more liable to put a lot more 3D printed things into Charcot patients. If we know we don't have to cut it, or if we're cutting off, it's not that big of a loss.
Well, and Chris, I've been playing around with this too, and it really is very impressive material, and it's amazing too, because just like regular bone, you don't have to pre-drill any of the holes or anything. You can drill right through this and put your hardware wherever you want, as if it was just bone.
Right, and it's nice because, as you're saying, so it's a customizable 3D implant, right? So when you get in there, you're like, oh crap, it's a little too big. Shave it down.
Shave it down. No big deal. The next question.
Yeah, that's a nice technology. I think, having something that's 3D printed that you can, customize, because one of the drawbacks with the metal is if it's not fitting, they usually send you 3 different sizes, small, medium, and large, but then you have to resect more bone. In this case, you're resecting more implant.
Exactly. So, you can customize it. You can fine tune it right on the back table.
Yeah.
It's pretty amazing. What's the largest gap you guys have done with 3D printing? This is the next question.
I'd say for that, I've done 4 centimeters, but I have friends that have done 10 and 12. I think if you really want to see real impressive gaps, you look into the trauma groups, where they're starting to really, especially like the proximal half of the tibia, they're salvaging, leaving the articular surface and filling in plateau. There are people doing, distal one half of the tibia, the total ankle in the oncology world. So we don't really know where the limits are with metal. I think you guys are showing we're already trying to change which metals are being used in different plastics, and Selene, you're the only one publishing on total taluses so far. And, we're waiting for more of that, and we don't know what the length. I think your last paper was 5 years, so we don't know where it is. Almost like technology keeps changing before
Changing faster than we can collect data. In fact, we did the world's first PEC total talus last week.
You did?
And it's as light as bone. It was amazing.
Cool. Yeah. So what is I guess my last question, since we got 2 minutes left, is, the big thing with the metal is it's got the biomechanical strength compared to allograft, and it doesn't matter if the middle of the metal doesn't have bone because it's strong, whereas an allograft will fail, like Giza showed. So what is the biomechanical strength of PEC over time compared, so Gross was showing that big defect. Do you worry about having to wait for it to turn in the bone around it before you really let them go? Because with my metal, I'm letting them weight bear in a boot at 6 weeks.
I mean, it's similar properties to titanium.
Okay.
Yeah. But I cheers to you for letting them walk at 6 weeks.
All right, guys, I got to wrap this up, unfortunately, because I got to get the next session going.
Well,
Great discussion. I appreciate it.